Welcome everyone to our Fall 2023 Trauma Anesthesiology Society podcast. Thank you for listening, and we hope you find the material engaging. Thank you, as always, to our partners at Doc Matters for recording and posting this episode. This is Kevin Blaine. I'm a trauma anesthesiologist at Oregon Health and Science University. On the line as well is Josh Sappenfeld, a trauma anesthesiologist at the University of Florida.
Okay, and we are very excited today to have us Dr. Milas from the University of Pennsylvania. Dr. Milas is an intensivist, an anesthesiologist, and she has been a tireless advocate for over-the-counter naloxone. For our international listeners in the U.S., until this year, naloxone has only been available with a physician prescription. Dr. Milas, however, has been working very hard to make intranasal naloxone available without prescription, which, by the way, thank you and congratulations. Since that happened back in August, like just last month, welcome, Dr. Milas.
Thank you, Kevin and Josh, for inviting me to speak.
Dr. Milas, some of us are familiar with your interest in naloxone, but many of our listeners may not be familiar with your personal story. Would you relate to us why this issue has been so important to you?
Sure, I'd be happy to. First off, with my background in cardiac anesthesia on a daily basis, I administer intravenously large doses of fentanyl. That's what I do, and that's what a lot of people in our audience do for a living. That's our professional experience. But my lived experience has been that I have, unfortunately, tragically, lost both of my adult sons to opioid overdoses, both accidental and both involved fentanyl. And I had on a number of occasions where I needed to deliver a naloxone product and fully resuscitate my son. This happened on a number of occasions, and I mean, if anyone in the audience can just think of how really terrifying that is to be in that situation. And I often thought too of how terrifying that it would be for any person in the lay public to be in that same set of circumstances, either not knowing what to do, not having the skills, and not having a naloxone product immediately available in their medicine chest. So that's why I go out and I teach in the public about how to Narcan rescue someone who's suffering a drug overdose.
Wow. I mean, I was freaking out when my daughter was having hives to a food allergy. I can only imagine how I respond if I came home and found out one of my kids was having issues because of an opioid. I mean, we use fentanyl all the time in the operating room. I mean, how bad is this opioid epidemic?
Well, we're talking to trauma anesthesiologists, and opioid overdose, really drug overdose, is the leading cause of accidental death here in the United States. One individual dies every 5 minutes due to drug overdose. And the majority of the time, over 75% of the time, it involves an opioid. So it is common, it happens frequently, and we lost in 2022 over 108,000 individuals. This is more than any other previous year. So COVID was really not kind to the drug overdose epidemic. So we're really in crisis mode. We need to, as physicians, teach individuals how to save a life.
I feel like the fentanyl overdose is becoming it's almost just another comorbidity that I take care of in my trauma anesthesiology practice. I hesitate to remember the last time that I saw a Saturday night trauma that wasn't on some combination of fentanyl and something else. So we see this pretty commonly, but why do you think that anesthesiologists in particular are so well positioned to advocate for naloxone?
Right, that is a great question. Quite honestly, in the health professions, there's really no group of doctors in particular who have embraced this. Now, the ASA and anesthesiologists, we have embraced this as a cause. We have the ReviveMe.com campaign. It's through our professional society. We've already started to talk to the public about this. And by the way, Revive is REVIVE, all caps, lowercase me.com. This is through our professional ASA website. On that website, that's how we can teach the public how to respond. So we don't have any other group of physicians who are doing this. We have started to move the ball forward, but we need to go further. We are educators for our patients and for the public, and we can go further. The public needs to see us not just as individuals who puts people to sleep in the operating room. We are educators in the public space, and we also push public health care policy in favor of saving lives. This is a fantastic opportunity for us to give anesthesiologists a public face and help define us as different from other practitioners or providers in the anesthesia realm. So that's why, in particular, I think this is a key opportunity for us as a profession in a time of public health crisis.
So I know, just working in the hospital, that anything of this magnitude is going to take a lot of effort, a lot of work, and people usually can't do this alone. Can you kind of give us a brief history of how we got here and just update us on the status of Narcan and how to get it?
Right. So just a little bit of the background is that naloxone as a nasal spray has been available for a number of years in the United States. It has been primarily available either through a statewide standing order that's written by the physician general of each of our states, or there's legislation in each state that allows for the dispensing by a pharmacist naloxone to the public. So you really didn't need a prescription over the past few years. You could just walk up to a pharmacist and ask them for it, and it would be dispensed to you, to anyone in the public who asked for it. The problem is that the pharmacy counter has proven to be a bit of a barrier for a number of reasons. One, the individual from the public does not want to be seen as an individual with a drug problem or to have their family judged as a family with a drug problem. Additionally, you have a pharmacist who may or may not know about the standing order or the legislation in their state, and they just may not understand the legal issue that, yes, you can dispense it, and you should be dispensing it to those who ask. So let's move the ball forward. Well, if that's a barrier, well, what can we do to make it easier for anyone in the public to obtain? Well, you make it over the counter, which is what I lobbied for. I testified before the FDA in February of this year, and March of 2023 was when it was approved for the drug to actually arrive on the counter in pharmacies, in Walmart, any large supply store, really. And that would make it easy, convenient, and stigma-free for anyone to just take it off the shelf. And, you can swipe it at the register and you can walk out and nobody needs to know. That can be kept private, but that allows everyone to have it available in their home. So I think it's a wonderful, wonderful opportunity. And quite honestly, we also need to change the narrative around Narcan. It shouldn't be that someone who picks it up and has it in their home, that they're identified as either an individual with a problem or their family has a drug problem. Instead, we should be talking about this as this is an indicator of I'm concerned about my community. It's a sign of good citizenship. I care about my neighbors. I care about people out in the public. And you could be a lifesaver. That should be the narrative. You could be someone's hero. That's what it means to carry a naloxone product such as Narcan.
Great. And certainly I can't wait to stock my own home pharmacy with my home pharmacy shelf with some Narcan. Well, what do you think the future is here? So I assume your work isn't done. So now that we've made Narcan more available for use, where do we go next?
Well, I think the next logical step is we need to saturate the public with naloxone or Narcan products. The missing link in this is it should be available out in the public, say in areas where someone might not be carrying it in their pocket, in their briefcase, in their handbag. We need to place a naloxone product next to every AED across the United States in this manner, to have people out in public spaces carrying it and having it next to the AED. That's how we can curtail the loss of life due to drug overdose.
I can only imagine like going out and almost proselytizing this. What would you say is the biggest barrier you've had to approaching people about Narcan and its distribution?
Well, I would say that it's the misconceptions and the stigma that people hold within themselves, that is the biggest barrier to carrying a Narcan or naloxone product, or to even being willing to intervene when somebody suffers a drug overdose. And it's the concept that, well, that victim, they did this to themselves. They started it and they should be able to stop. And that is clearly a misunderstanding of the problem of substance use disorders and addiction. That's really a lack of understanding, which I try to educate people as why they cannot stop. And oftentimes, too, it takes us into a discussion of there are many behaviors that people engage in that lead to disease and illness, like cigarette smoking, having a sedentary lifestyle with a high fat intake. Those are things that people engage in, behaviors, and that leads to disease. And we don't shame them. We don't not intervene on them. We assist them. And the other concept or misconception that I hear about a lot or I see is that when people think of someone who is a substance use disorder individual or someone who is a user, or let's use derogatory terms I hear, a junkie, they picture someone in, say, Kensington, in my local area, or in the Tenderloin area of California, where it's somebody who's disheveled, they've got a needle in their arm, they're dipping out, they cannot stay awake, and that's what they envision. And also, what is attached with that is that these are somehow dispensable or disposable individuals. But that's not the face, the sole face of drug addiction. Yes, those people are affected, no doubt. But there are people that we work with who are equally as addicted to substances. You just don't know it because they're able to maintain themselves either at work, and they're able to maintain their look. They look normal. You know, my boys look normal, and you certainly would never have known what they were struggling with. And I go out in the public, I tell my story. I'm a doctor who's lost, tragically, 2 sons, and they were productive members of society. So we need to help to change that narrative.
Dr. Milas, this is kind of a follow-up question. How do you think we should change that message?
I think the best way to help change that message is to point out when we are talking to patients or when we're with people socially, that we can point out that that is a misconception and that is not true. And you're more likely to run into an individual who is overdosing on public transportation, in a public bathroom, whether you're out at a sporting event, that you will come upon this situation. And, just thinking back, that I'm just going to mention, it's a different situation, but the Damar Hamlin episode where we were holding our breath, and that was a scary circumstance. Instead, this is a situation that you are going to walk in upon, and you may call 911, but you're going to be faced with, well, what do you do? Do you intervene or do you turn your back? And if you intervene, do you have the skills? Do you have anything around to help save this individual? Because you're looking at them and they are actively dying in front of you. It takes an average of 7.5 minutes for the EMS squad to arrive. And what are you going to do in the meantime?
What is harm reduction? I don't even know what that is.
Well, great question. I get asked this question, what is harm reduction? Well, it's really a multi-pronged concept. So first is how can you protect yourself? And I like to think of this as injury prevention. So we counsel people that if you're going to use, please never use alone or overnight, because there's nobody around. That's pretty obvious. If you have been abstinent for a number of days to weeks to years, whether you were just released from rehab or you were released from jail, quite honestly, that if you're going to use, to please go slow, use a much smaller amount than what you were used to using, to always have someone around who has naloxone, and to please test your product. So we now have fentanyl test strips and xylazine test strips that can be used to test the substance before the individual uses it. And they are legal in nearly all states, 10 remaining states that still consider those test strips to be paraphernalia. But that's really the concept of harm reduction, injury prevention for those who use substances.
So, what would you say? What would you say to one of my colleagues who hears about that naloxone is now available for community use and thinks, "Well, I'm not going to walk around with a syringe and a vial." Thinking about the naloxone that we use in the OR. How would you answer that?
Well, the best answer to that would be that no, I would not expect you to walk around with a syringe and a needle in your pocket, that it is a very simple nasal spray that any layperson can give. And if they can give it, I would certainly expect any one of our ASA members to be able to deliver it safely as well. And by the way, it is small. You take it out of the box, which has 2 doses of 4 milligrams in the box, and it is probably a 2-inch by 1.5-inch little package. You could put that with a pair of gloves, and if you felt the need to, put a little plastic face shield in it, and you are equipped to respond to a drug overdose in your community or in your home. It fits in the breast pocket of a jacket, and it fits in even the smallest little evening bag that I have carried when I've gone out at night for a performance.
Do you see much acute opiate withdrawal when you use intranasal Narcan on folks who are overdosing?
I would say usually not acute withdrawal caused by intranasal naloxone. And the reason being is because fentanyl is readily mixed into the substances that people are buying, and therefore it's obviously much more potent than heroin. So it frequently takes 2 or 3 doses in order to revive someone. And you have to space them out 2 to 3 minutes apart from one another. And if you're not getting the appropriate response, where someone starts breathing again and they become conscious, that's the reason why you would repeat a dose. But I would say generally not, as long as you're not rapidly giving successive doses. But it can happen. Generally, the symptoms are what you would expect. It's runny nose, agitation, goose flesh, vomiting. Those things can happen and people can get agitated. So I would always instruct someone who's going to rescue a drug overdose victim is to please give them their space, to not hover directly over them as they are emerging from the opioid or the overdose, and to explain to them what happened, because it's a very confusing circumstance for them. They have no idea what's happening. They don't remember necessarily where they are. And there they are on the ground. They're feeling sick. And you are obviously crouching over top of them. So just give them some space, let them know what happened, and to encourage them to get into the ambulance or to go on to whatever is their next step in their recovery.
So, there's a lot of I think misconceptions in the healthcare community about treating patients who present with particularly a fentanyl overdose, and people are worried about contamination of operating rooms and ERs, and they're worried about themselves getting hurt from treating patients who have contaminated themselves with high potency opiates. Should they be? Should we be concerned about this?
I would say, due to the experience that has been occurring with police officers and first responders, I would say no, that our medical personnel who are treating them either in the operating room or in the emergency room are very low risk of cross-contamination. So the fentanyl powder is poorly absorbed through the skin. You really have to inhale a significant amount of aerosolized particles or liquid in order for that to occur. It's certainly, although you may have seen viral videos of police officers collapsing, all 4 limbs rigid, that is not and was not a fentanyl cross-contamination or overdose. In the first responders who have had such experiences, they've done drug testing and there was no fentanyl that was found either in urine or in blood samples. So I would say that our healthcare providers in the operating rooms and in emergency rooms are safe.
Well, great. I mean, this was a lot to think about and a lot to digest. It's clearly an important topic. It's affected us both professionally and personally. And we look forward to learning more about it at TASCon 2023 here. Well, not here in Florida, but here at San Francisco before the ASA annual meeting that Friday afternoon on October 13th. We'll have a link to it in the TASCon registration. If you're staying around for the ASA annual meeting, be sure to stop by the Trauma Anesthesiology Society Science Exhibit to learn more about ASA's Revive Me campaign and learn about ways to participate.
Dr. Milas, thank you again for speaking with us, and thanks as well to Doc Matters, who are our hosts. We look forward to our winter podcast. If you have any suggestions for a trauma-related topic that you'd like to discuss or a speaker that you'd like to recommend, please reach out to us. We're especially interested in speakers from our international members. Thank you very much for your time, and see you in San Francisco.